All right, so I'll start with the introduction, Peter, and then you can present after that. Thanks again for doing this for us. Welcome, everyone, to Health for the World International Grand Rounds. We are honored to have our Grand Round speaker today. All right, so I'll start with the introduction, Peter, and then you can present after that. Thanks again for doing this for us. Welcome, everyone, to Health for the World International Grand Rounds. We are honored to have our Grand Round speaker today. All right, so I'll start with the introduction, Peter. All right. So sorry about that. I think the YouTube live is echoing with us. Okay. So Peter is a professor of infectious diseases at UCSF. He earned his undergraduate and medical degrees from Brown before completing an internal medicine residency. All right. And infectious so sorry about that. I think the YouTube live is echoing with us. Okay. So Peter is a professor of Peter, you go ahead.
Great. Thanks so much, Bhavya. And it's my pleasure to be here today to talk about monkeypox and where we are and where we might be going. So I have a few questions that hopefully by the end of this talk, I'll do a relatively short talk and leave it open to Q&A as well. So where did it come from? Who's getting it? How do patients present in this current outbreak, which is a little bit different from previous outbreaks? How do we diagnose it now? How do we treat it? How do we prevent it? And what is the future? So right now, as of yesterday, there are 31,800 cases around the world in 89 countries. Over 80 countries haven't seen monkeypox before. And in the US, we have 11,890 cases. California and New York are the two highest number of state censuses, with LA and San Francisco being about half and half in California. And if you think about a population of San Francisco, it's so much 10 times smaller in LA. So if it's the same numbers, you know that the density is much higher in San Francisco, where we are. Oops. So where did it come from? Well, first of all, I want to just start with one brief microbiology fact or virology fact, which is monkeypox is a DNA enveloped virus, which is meaning that it's pretty stable as opposed to COVID, which is an RNA virus. So it generally mutates much slower than SARS-CoV-2 does. There are lots of famous relatives of Mpox or MPX, as California is saying. Today, the WHO is meeting to rename it, but I'll use it as MPX, Mpox, or monkeypox throughout this talk. So there's smallpox, which is the variola virus. It's the human version of monkeypox, and it's much more transmissible. The virus is much more engineered to cause destruction in a human with smallpox as opposed to monkeypox. Of course, smallpox is the first disease for which there was a vaccine, and it's the first disease that was eradicated. In fact, in the 70s, we stopped immunizing against smallpox, and many parts of the world followed suit. Some did it a little bit later in the early 80s. Cowpox is another famous relative. Of course, cowpox is what cows got, and then the milkmaids never seemed to get smallpox. So Edward Jenner in the UK had this observation, took some of the cowpox and injected it into humans, and they seemed to be protected. And that was the first model for vaccination. Vaccinia virus is the virus related to smallpox in the smallpox vaccine. And then there are lots of other variants of monkeypox that affect different animals, like camelpox, horsepox, raccoonpox, conkpox, bullpox. Chickenpox is not part of the family, although it has a very similar name. That's a different family. That's the herpes virus family. So monkeypox is generally thought as a less deadly smallpox. And when you look at what happened over the decades with monkeypox, It was first identified in 1958 in Denmark in some research monkeys, and that's why it got the name monkeypox. But as many people in this audience knows, it should be called rodent pox or rat pox, because that's really the sweet spot for the animal population that it affects. And then by the 70s, there were at least 47 cases seen in the DRC. 1972, USA stopped smallpox vaccines. It was declared eradicated in 1980. But then what happened is that they started to be seeing more and more outbreaks around the world, particularly in Western Africa and Central Africa, since the eradication of smallpox and the cessation of smallpox vaccines. So the outbreaks are becoming closer and closer together. And even before this outbreak, there was a lot of advocacy to do more research and get vaccines for, deployed to the areas of the world that needed it. But there was a lot of stasis, as many things in life, when there's only one part of the world affected. In 2003, we had a very famous outbreak in the United States, and I'll delve into that some more in the next slide. And then, every year we get maybe one or two cases, usually from travelers, until this case, with so many tens of thousands of cases around the world. So in 2003, there was a large outbreak of monkeypox seen in Wisconsin. There were 72 cases, and what happened was that these prairie dogs are native to North America. They were being sold in swap markets in several states, and they were housed next to these Gambian rats they were all brought in for exotic pets. The rats had monkeypox, gave it to the prairie dogs, and then the owner of the dogs, the dog farm, took them to the farmers markets or swap markets to sell them in all these states. And when people got these prairie dogs, they all got infected with monkeypox, with a degree of disease based on how much you interacted with the animal. So it actually gave us a lot of ideas about how you actually get monkeypox most efficiently, which is not really through respiratory, it's actually by direct contact. And in the case of this outbreak, skin-on-skin contact. So who's getting it? Right now, cases are rising very steeply. And we don't have enough vaccines, which is probably going to be our salvation for monkeypox, because it's so hard to diagnose clinically. So in the yellow line is the rest of the world, and in the blue line, it's the United States. So, it would have been easier to control it in the flatter part of the curve. But like with many things in our response, even having a slower but faster than before response is not enough really for these fast-moving outbreaks. So right now we're seeing monkeypox in men and trans people who have sex with men. About 99% of the cases are men. Globally, 98% are self-identified as men who have sex with men. And what happened is that there were two events in Europe, two raves, one in Canary Islands, one in Belgium. People from all over the world went there, and then they went back home to their countries. And then it was around the same time as Pride events in many countries. So it got amplified by these events, as well as in gay saunas and gay pool parties, not regular pool parties. In the US, actually, right now, there are not 5, but 7 cases, 2 in California, and kids. And they all thought to have gotten it from household contact from somebody in the household who had monkeypox. And now the CDC has very clear guidance as to how to protect yourself if somebody in the household has monkeypox. There've also been a few women around the world, including US, tens of women across the world, but nothing compared to the tens of thousands of men right now. Yesterday, there was a first report of a human to pet transmission of monkeypox. It was in France from a couple who had monkeypox, didn't keep their dog away, and the dog slept with them in the bed, and the dog got monkeypox 12 days later. So this is the first case that domesticated animals can get monkeypox from a household contact. And it also, reminds us that monkeypox is really trying to get into animals and small mammals. And one worry is that it may get into the domesticated or wild animal population, and you can't really control it at that point and becomes endemic. How do patients present? Well, what this outbreak illustrates is that people are not presenting in the same way that we saw in the textbooks from the classic cases of monkeypox. It's mainly in the context of intimate contact, not a traditional sexually transmitted infection with body fluids, but rather skin-on-skin contact with a potential contribution from body fluids. Most times people are presenting with symptoms about 7 days since exposure, but in one study is up to 11 days and another study is 2 weeks or 3 weeks. So basically longer than say COVID, which is in a matter of 2 to 3 days. Most people present with flu-like symptoms at day 7, so a week after. And the top 5 symptoms are fatigue, fever, lymph node swelling, which is very specific or unique to monkeypox, myalgias, and sore throat. But notice that about 20% of people have no flu-like symptoms, and the first presentation is with a rash. Almost pretty much everybody gets a rash, and in this particular outbreak, it's at the point where there was contact. So in 94% of the cases, it's in the anogenital area, and then the movement of the rash is what gives it away. It moves to the face, mouth, arms, and palms and soles. We've had about 10 to 30% of people hospitalized based on the country, and people are generally hospitalized for 2 things. One is for uncontrolled pain, because these are really, really painful. And the other is bacterial superinfection, like another bacteria complicating the open sores that people have with monkeypox. There's been a death in Brazil, 2 in Spain, outside of the African continent in this particular outbreak. And but generally not a heavy death toll. And the clade of virus that we're seeing with this particular monkeypox outbreak is the West African clade, which is about 1% mortality traditionally, as opposed to the Central African clade, which is about 10% mortality. And all the information about high mortality in kids and pregnant persons come from the Central African data. So it probably doesn't apply necessarily, but we're still being cautious in looking at those populations. So some pearls about the rash. Like I mentioned, it generally follows the flu-like symptoms. It starts in the genital area, skin on skin. It has a lot of mimickers in the early stages, so that's why diagnosis is a problem. So it may be initially missed or mistaken for herpes, syphilis, folliculitis, abscess, a pimple. But the movement of the rash is key. It starts off there, but once it starts moving to other parts of the body, I think most people realize that it might be monkeypox at this point. May seek medical attention or not, because it's still pretty much stigmatized. The rash can be umbilicated, so there's a little hole like a donut in the middle. They're often extremely painful, and it can give you rashes on the palms and soles. Then it crosses over, scabs, and falls off in 1 to 2 weeks. The period of infectivity is really from the time of the flu-like symptoms to the end of the scabs falling off. So it may last about 3 weeks in total, but there's no pre-symptomatic transmission phase as far as we know with monkeypox, as opposed to COVID. How do we diagnose it? Well, diagnosis is mainly through PCR, a dacron swab, a polyester swab, or nylon in at least 2 sites. Don't use cotton swabs because they cling on to the cells and they don't release them to do the PCR. You can even send it dry to, there are 5 commercial labs in the US doing it now. Many countries, states set up to do the PCR tests. And we're not sending enough tests in the United States. Even though we have capacity for like 100,000 tests a week, it's really, really a trickle. And that's because it's really tough to diagnose in the beginning. And people, I think, are being too strict in how they decide to send a test. And also, they're only really swabbing the skin. So you can imagine when people come and present with disease in the anal area or the mouth only, you can swab the skin forever. You're not going to get any DNA. You have to really go where the disease is. And I think a lot of people are not doing that. We haven't really gotten a lot of great guidance around non-skin sites with PCR. How do you treat it? Well, in the US, we're lucky to have access to tecovirimat, which I know is not true for most of the world, unfortunately, but I'm hoping that we could upscale the production of these meds, even if vaccines take a while to produce. There's not a lot of randomized control data around it, but there's good animal studies. It is FDA approved for smallpox, and of course, there's no randomized control data for smallpox either, because nobody would be randomized to smallpox trial in that way, and there wasn't a lot of smallpox around. So a lot of the FDA approval for smallpox comes from immunobridging studies where they just look at antibody response fold. And there's also, 1 or 2 studies with tecovirimat in terms of safety in a few hundred people, showing that it's really, really well tolerated. In my own patients, they've been really, really well tolerated. Like, I haven't heard any complaints. It's more acceptable than even like ibuprofen or Tylenol, it seems. So it's 3 pills twice a day. It's an IV formulation, also an oral. And the way we get it is through expanded access in IND. The CDC has a IRB, the CDC has a consent form, but it's up to your IRB how they interact with the CDC's approval process and whether or not they use something called an intent to rely. But it's a real big barrier, and you need a lot of activation energy to start it, at least psychologically, even though when you get everything together, it's not too bad. We have about 2 million courses in the national stockpile. Right now, it was developed really for smallpox in case we got attacked with biowarfare, but it's now being deployed for monkeypox. Equity remains a big issue because there's not a lot of it. So it's people are in a conundrum. There's not a lot of clinical data. There's tons of personal experience, case studies, virological work, and animal studies showing that it works really well. And should you study it? Should you wait for it? Should you ramp up production? Should it be an emergency use authorization like Paxlovid, where more people can prescribe? I think we're in a tough spot. But because it's so well tolerated, I think many people believe that it should be an emergency use authorization in the US, have a low barrier for prescribing it. And patients, in my experience, tend to do really, really well. Like this patient, which is my first patient in UCSF, who we treated with tecovirimat. On day 0, he had like the most extensive lesions all over his body. You can see it on his palms. And by day 3 of antiviral drug, they were pretty much disappearing. He talked about having better self-esteem, and I'll show you a quote on the next slide. So the way we are treating now is kind of like in the early days of COVID, where we're treating the sickest patients first. But of course, with any antiviral, this audience knows that the earlier you treat it, the better it is normally. So I think it will probably end up being early treatment with tecovirimat if there isn't an issue around availability and barriers for getting it. But still in the late stages, it's doing really, really well, at least in my experience. Of course, no control group. So we're usually treating people if they have bad disease or if they're concerning hosts. So bad disease are generally hospitalized patients or people who are not hospitalized, but they have disease near their eye, their mouth, their urethra or rectum. And that's because of the pain and inability to eat, for example. Close to the eye, it can cause potential blindness. So that's why we'd probably want to treat those. And concerning hosts include severely immunocompromised, less than 8 years old, again, based on that Central African clade, which this is not. But we still want to treat kids cautiously and liberally. Pregnant or breastfeeding persons, and those with inflammatory bowel disease or severe or active dermatologic disease. Because when you get monkeypox on top of something bad, it can cause strictures, for example, in inflammatory bowel disease and make it worse. So this was a couple of my patients and their quotes after taking tecovirimat. I feel night and day to what I was experiencing this weekend. Actually, since the day after UCSF, I didn't need to take any painkillers, even to sleep. Prior to that, I had trouble sleeping even more than an hour at a time. New lesions have stopped appearing, and all the ones on my body and face seem to be healing and peeling. Yesterday, it was still difficult to walk, but today I can walk at a semi-normal pace. My hands and toes just feel numb, but I assume that's due to the coat of dead skin on them. I fear especially how this will impact the most vulnerable amongst our community. I'm a highly privileged remote worker, high earner, ample paid time off, with a partner who can care for me and no dependents. I was completely debilitated, but got through okay. I can't fathom the damage monkeypox can do to a gig worker or a temporary worker or a single parent. So this is just a schema of how we do it at UCSF in terms of distribution of drugs. Any clinic or the ED can refer a patient for secondary evaluation. So it's the primary evaluation is done here if pictures are taken. If they fit one of the criteria, then infectious disease would sort of like screen them, consent them, which takes an hour because it's still investigational. And then we schedule 2 follow-up visits, which is part of the protocol because it's still considered an investigational drug, even for monkeypox, even though, as I mentioned, it's FDA approved for smallpox. How do you prevent it? Well, the 2 main vaccines are the old smallpox vaccine, which we have one for every single American in the national stockpile. But because it's live and replication competent, there's a risk of myopericardite was seen particularly in military recruits after 9/11 when they were giving them smallpox vaccines. It's not currently recommended. It can also, because it's live, cause disease in patients who are immune compromised. So we're using the live replication incompetent vaccine made by the Danish company Bavarian Nordic. It's called Jynneos. It's safe for everyone, and it's now FDA approved. Actually, this is I didn't change this part for those under 18 under the emergency use authorization passed last week. And now we're set to use 5 times the doses by giving it intradermally, like a tuberculin skin test, instead of subcutaneously, because there are a lot of more immune cells in that intradermal layer, so you need to use less. There is 2 studies showing that it provides a robust immune response, and we have no other choice but to deploy that way because of the demand for monkeypox vaccines right now. It's been studied in a lot of other vaccines when in yellow fever outbreaks before in the African continent, when there was scarcity of yellow fever vaccines. They also divided it up and gave it intradermally and was successful. It's been studied with polio and influenza, hepatitis B, and a whole host of other infectious diseases. So this is basically, still hasn't really been deployed, although people are being trained now in the sites to begin administering this intradermally in the US. The other aspect of the vaccine is that we've also prioritized first doses. So in the strict way of giving this vaccine, you give it 28 days apart, 2 doses. But again, started off by the UK and Canada and New York, California, and several other areas around the country moved to prioritizing first doses and then waiting until we have more vaccine to give second doses. I think most people think that will be okay. The first dose is meant to be like equivalent to dose 1 and 2 of, say, a Pfizer vaccine for COVID. So it's the priming, and the second dose is really the booster. But again, people are uncertain because it's really a high inoculum in the skin-to-skin contact. But so even though it may not prevent 100% of disease, it probably will prevent the virus from getting to other parts of the body and disseminating. This has been very controversial because a lot of people are afraid of monkeypox now in the general population, but it's primarily skin to skin. I put this intentionally in large font to small font because it just shows the relative importance of what we know about transmission. Again, most people think it's skin to skin, bodily fluids, maybe. You find it there, but we don't really know what it means for transmission. The blood bank has I think a window period of 28 days after monkeypox before you can donate blood now. speaking to the fact that you can find it in blood. And of course, it must be in blood to get to other parts of the body from the genital area. But fomites and fabrics and towels only really in the context of household no exposures. The only really documented case of transmission from the air was in a healthcare worker in the UK who was taking care of a patient with monkeypox. They didn't know it was monkeypox at the time, changed the bedding of the patient, and the scabs went in the air, and the healthcare worker got monkeypox on the face. So that was the only sort of like real documented. Other than that, it's really skin to skin and maybe a contribution from bodily fluids. Droplets are possible. Of course, smallpox has a big respiratory route, but monkeypox being an animal virus, you really need a lot of it to cause disease in patients. So droplets, probably 3 to 6 hours of constant exposure to someone, as opposed to 10 to 15 minutes with SARS-CoV-2. So everyday exposure in public, going to the thrift store, going to the gym, going on public transit, going to be very, very small risk at this point. But again, things are fluid, and the longer this stays, it may bleed over into the general population, but so far, not so. I really like this article in Stat. It really gives the up-to-date information about transmission, citing some studies, and even though they're small studies, the newer studies, it is a nice summary. So what is the future? Well, there are 4 possibilities. One is that we have a self-limited outbreak where this kind of burns out, but it doesn't seem to be the case when you look at these curves going up. And we don't have enough vaccines either for the US or for the rest of the world. It's really hard to diagnose it, like I mentioned, particularly early on. What I didn't mention is how stigmatizing it could be, although I have a slide coming up about that. And the reason why that's important for diagnosis is that on vaccines, can you imagine right now with the focus on the queer community, if you ask for a monkeypox test or you line up publicly in a line right now, it's almost like you're telling the world what your sexuality is. And there are many people who won't feel comfortable doing that. So I'm worried about that part in terms of protecting all members of the community. We do know that there is a big disparity already setting up in the United States, with about 30% of Latinx in San Francisco, Santa Clara, and about 20% in New York, which is about double the population in that particular community. So again, there are lots of things going on that we don't fully understand. So it could be self-limiting, although that seems less likely at this point, although I'm still hoping. It can affect the entire population where it bleeds over. So the first population I think people are worried about is the college students, because again, very sexually active, close quarters, wrestling teams, all of the places where we normally see diseases and outbreaks like Staph aureus, skin disease, and things like that with close skin-to-skin contact. So maybe if we have more enough vaccines, it could be broadened to another population, in terms of being proactive. But right now we don't. It may become endemic if it gets into the animal population. And from the animal population, it can then cause recurrent large epidemics or outbreaks from time to time. So, those are the potential scenarios for what might happen. And what also might happen, and what is already happening, is stigma. So we already had reports of phlebotomists in some parts in the US being nervous about taking blood from patients, even if they suspect monkeypox, without knowing for sure they have monkeypox. So that has really been a scary start. And then this person was really unlucky because she has neurofibromatosis, which leaves these visible lesions on the skin, which look like the old way of monkeypox with the big boils. So somebody took a video of her and posted it on TikTok, and she was publicly shamed, and she went forward to talk about this. Again, speaking to the public fear and hysteria around monkeypox. Even when a rash in a kid comes to her school with a rash, there's a lot of anxiety, could that be monkeypox? Should they stay home, etc. I mean, I think in general, when from an infection control perspective, if you cover the rash, you lower the risk of transmission tremendously. I still have time, so I'd like to see if I can show at least part of this video. This is my patient who contributed in this video with the Wall Street Journal. At least I'll show a few minutes just to show you what his words were.
Peter, yeah.
Right now, petabytes of data are streaming around the globe with the power to transform your business. Harness the power of real-time data. Right now is the time for AeroSpike.
I was having a lot of fatigue and body aches. I just thought it was exhaustion from traveling. But the next morning, I woke up with rashes all over my hands. The lesions started spreading to the more usual suspect areas. So that really made the doctors sort of confirm that what I had was monkeypox.
Kevin Kawang believes he was first infected in late June, about a month after monkeypox cases began to be reported in the US.
It was sort of this mystery disease. I think I approached things cautiously, but at the same time, I wasn't even sure what to be aware of.
By late July, the World Health Organization declared it a global health emergency, their highest level of alert.
It will not be the next COVID-19 pandemic, but as a public health professional, I am very worried about what's unfolding because this has the possibility to become a new virus that circulates regularly.
So how does monkeypox spread? And what can be done to contain this outbreak? It's called monkeypox because it was first detected in research monkeys and because it's closely related to smallpox.
The way I think about smallpox, it's the human version of monkeypox. It's not engineered to exploit human cells and human bodies. We're like an accidental host. So I just wanted to show you a bit of one of my patient's words, and you can look up that video on YouTube. It's actually quite well described in terms of the graphics, in terms of transmission and the patient experience and some of the problems that we get with diagnosis. So I think with that, Bhavya, I think we can open it to Q&A or do any other protocol that you like.
Yeah, thank you so much, Peter. We really appreciate this. And there were some issues with YouTube Live at the beginning, but for those who do not know Peter, Dr. Pinchin Hong is a Associate Dean for Regional Campuses at UCSF. He is a Professor of Infectious Diseases at UCSF and a world-renowned educator. Has got numerous teaching awards, and including the inaugural holder of the Academy of Medical Educators Endowed Chair for Innovation and Training. So thank you so much, Peter, for the wonderful talk. It was just excellent. Please feel free to put the questions in the Q&A. Before more questions pop up in the Q&A, Peter, I had a few questions which came up before this talk, and people had submitted some questions about monkeypox. So I think the main concern remains, Peter, is that as you rightfully described, that there is clade 1, clade 2A, clade 2B, and it seems what is circulating for the global populations for the outbreak is the clade 2A and clade 2B. I think the biggest question is, what are the chances of it getting mutated to a highly transmissible variant? I was looking at the literature. Some literature shows that it's a very complex viral structure. So the chances of mutations to highly transmissible variant is low. But others said they don't know. So I just wanted to see what your thought is about this,
I think those are all excellent questions, Bhavya. I think that there are more mutations in this when they do genomic analysis of this particular strain that of the clade that's circulating, and people don't know what they mean. But we are seeing new things that we haven't been seeing before, like so many people at the same time, and human to human isn't as effective as what we're seeing right now. So either it got into the right population at the right time, or it has evolved in some way. also like the fact that the dog was infected in France. That's the first time a domesticated animal has been infected with monkeypox, at least as we know it. So it was thought that dogs and cats were not didn't get monkeypox. But again, we're seeing a lot of firsts with this virus. So I think it's important to keep an open mind, but at the same time, not to be panicked.
Right. Oh, that's great. As far as the vaccines, Peter, we have some countries joining which do not have access to vaccines at all. So in that particular situations, in the areas of the world where vaccine is not available, what else can be effectively done for like prevention, both pre-exposure as well as post-exposure?
Yes, no, those are great questions. So pre-exposure, it means really targeted messaging and not average messaging. I think it's easy. In COVID, we got used to just an average message and one size fits all. But I think it's important in this particular outbreak to have very, very specific messaging to different groups. So for men and trans people who have sex with men, you have to be very, very explicit. Actually, I was surprised that the CDC has very, very specific guidelines to that population, but it's important to be as specific as possible. So now people are talking about recommending limiting sexual activity in that population, or at least limiting it to known people within a group and not anonymous. So that's harm reduction, but you want to meet people where they are. So I always ask people, where they are in terms of trying to give them advice based on their stage.
Right.
So that's the sort of idea of the pod, and then limiting sexual activity. And then in general, some good practices that we always talk about for any sexually transmitted infection is just having an open conversation with any new intimate partner. This is how I'm feeling, how you're feeling, tell me. And I ask this to everyone. And then maintaining touch with that person after, so that if they were to get ill, they can tell you, so you can again take steps. So if in some countries you have access to a vaccine, you can take the vaccine within 4 days to
Right.
avoid getting disease, or within 2 weeks if you haven't gotten rash yet, to decrease the expression of disease. And then people are talking about using the pills, which might be easier to ramp up than the vaccines, just like Paxlovid is, as
Right.
post-exposure prophylaxis. So
Right.
those are all things to think about. But again, the conversation is the most important thing, the trust, and then a temporary state, at least, of limiting sexual partners. Although people want to be sex positive now, it's really important to be very specific.
Yeah, that makes sense. Those are excellent points, Peter. As far as the vaccine availability within US, do you have any any knowledge about when will the vaccine be widely available, for the population?
Well, they ordered something like 5 to 7 million for next year. We don't have enough for everyone this year. That's unless they multiply by 5, then we might maybe target the at-risk population. But next year they're ordering, if they do the multiply by 5 intradermal administration, if they order like 5 million, then it'd be like 25 million, which I think would be enough for anybody who wants to get it
Right.
at that point.
Right. And in the intradermal has a lower dose, so the chances of distributing into population is higher.
Yeah, and it's much easier actually, though people are talking about training. It's like, you're giving an intradermal, although if you give it too much, it goes in the skin. If you give it too deep, you need more. But, lots of people give PPDs all the time.
Right, exactly. And I was looking at a video from CDC, which was saying that it's equally effective and, that will increase the chance. So as far as the high risk group, it seems people with, apart from the group which we talked about, weakened immune systems, children under 8, pregnant women, all of these are also at higher risk, should these groups be prioritized, and healthcare workers, should these groups be prioritized over the others for vaccines, in different countries,
I mean, I think it's going to be hard to see. I think they'll probably go with where disease is. So because the UK did an interesting analysis of what the test positivity rate is in different populations. So in the men they looked at, it was 50%, which is way too high anyway. that
Mhm.
means that they're not doing enough testing, because you want it to be like less than 10%, just like COVID, because the high number is concerning, but it also means you're not testing enough people. Because it's like appendicitis, using a radiology analogy here, Bhavya. It's
Yeah.
like you have to do a lot of CTs to find the few appendicitis
Yeah.
cases, because if you're only waiting to do the CT on the no-brainers, then you're going to miss. So it's the
Right.
same with diagnostics in monkeypox. So 50% in men, I think, 10% in women, or 6%, and then 0.6% in kids. So it means that even in a household contact situation, it's still not that transmissible. But nevertheless, I think with enough vaccines, if it becomes endemic, I wouldn't imagine that there won't be a population that people will be interested in looking at, because they're very much all over each other, saliva and bodily secretions, in terms of the playground and cuts and bruises and things like that. So, but the
Yeah.
first population, I think, outside that people are talking about is college students,
Right.
as another group.
Yeah. And when you mentioned UK, I read about the ring method which they're using,
Yes.
so it's vaccinating the healthcare workers and anybody in that, who is exposed.
Yeah, and they used that in the monkeypox outbreak in 2003. They use a ring method to control. So you just vaccinate around the ring of the contacts. But there's so many contacts now
I know.
that they can't keep up with it, and at least in San Francisco.
Yeah, that makes sense.
Bhavya or Peter, this is Bill. I just had a question about the healthcare workers who might be treating patients or dealing with them. Could you perhaps talk a little bit about the prevention of transmission for those individuals who might be listening?
Yeah, so right now at UCSF, we're being very, very conservative. So it's N95 plus a gown, because you don't want it to land on the surface because of that UK transmission from the patient I described, and eye protection. So those are the things. It's similar to COVID, except they're being conservative right now using N95. So that's kind of what UCSF is doing in the sort of like in the inpatient setting. But really, the main protection is probably your clothing, because of the potential transmission from scabs, and then secondarily your nose and mouth, and then gloves, of course. And then in the home, for known case, there's a bunch of things that people are doing, which is similar to COVID: isolating, own bathroom if you could, separate utensils. Laundry is really a new guidance from the CDC, where you keep it in a fabric bag and you wash the bag with the clothes. I have my stuff here. Monkeypox has an envelope, and this envelope is very fragile. So a lot of detergents and stuff kill it. So that's why washing in a regular wash will be good enough for monkeypox.
All right, that makes sense. There's a question in the chat. First of all, thank you for the excellent lecture. Do the skin lesions typically result in permanent or chronic scars?
Oh, that's a great question. So far, people have not been having permanent scars, luckily, that I've seen. It's not like smallpox, which leaves a lot of scarring. Monkeypox doesn't seem to be doing that as much, in my experience.
Okay, that's
in
great.
this outbreak, anyway.
Okay, that's great. And a question about, are the monkeypox infected patients, do they need isolation, and how long is the patient infectious once infected to a person?
Oh, that's such a great question. So again, we don't think there's pre-symptomatic transmission in monkeypox. There's a study in Belgium from this outbreak where they went back. And so it was a very small study, but looked at the people who had positive monkeypox tests, even though they didn't get monkeypox till later on. So in that time between when they went back to the clinic samples and tested them to when they had symptoms, they looked at their contacts, and there were no contacts that got infected from these known cases of asymptomatic patients. And that's the teaching with monkeypox as well. So you infectious from the time when you have the flu-like symptoms, and going all the way to the healing of the rash to the public. But in terms of an intimate contact setting, the UK is saying only sex with condoms for 2 months after for all patients because it could be potentially viable in semen or vaginal fluids, because they found it for like 19 days. Then the 2 months is just being very conservative. So people don't really know what to do with that information at this moment, but there's a period of time, even after the rash falls off, where for intimate contacts, you probably want to use protection, but for the rest of society, it's actually quite a long period. It's not like 10 days or 5 days of COVID. You're talking about somebody staying out of work for 3 weeks.
Right, right. And some of the doctors here, they were vaccinated against smallpox. So is there cross immunity between smallpox vaccine and the monkeypox?
Yes, it's cross immunity, although there's waning of immunity. So the recommendation is if you're at risk and you can get an updated vaccine to get it. But anecdotally, the median age of the patients in the world and in the US is in the 30s. And I see the people with severe disease because they come for evaluation for treatment. And I would say I'm not seeing anybody really over the age of 50, which suggests that they might, even if they're not protected, because there have been people over the age of 50 who've gotten disease, but not a lot of them. And I haven't seen any with severe disease. So it suggests that maybe even receipt of a smallpox vaccine in the remote past may, at least lower the risk of getting serious disease in the current outbreak.
Right, that makes sense. Question from actually Dr. Barry Bacon. He said, "Thank you, Peter, for excellent presentation. We are not seeing it yet in the rural Eastern Washington. Interested in any recommendations for us to be ready for this?"
Yeah, I think that recognition is key, and I think using and sending PCR tests liberally, because again, I think we're not sending enough of them, and even if that might be a pimple or something look like a pimple in an at-risk patient, send that. So I think the first thing is recognition. Secondly is knowledge that if in the US we're very blessed because we have access to drugs and to vaccines. And again, if you have access, particularly the drugs, and the patient gets sick or is on a bad trajectory, you can get that from the CDC and any part in the United States. So I think just knowing that, and then knowing how to counsel the patient who has suspected or known monkeypox in terms of household contacts, and how to protect yourself as well. But even if you didn't think it was monkeypox, and then you found out later it was monkeypox, it's going to be unlikely to get into a healthcare worker unless you're doing something invasive. So we've had a couple of cases of patients presenting with inguinal abscesses, what looked like abscesses, but it actually was monkeypox. And the provider IND'd it in the clinic, and then they got monkeypox from that. So I think it's really important to be protected in all settings when you interact with patients, particularly with something. I think the person, it was probably just something small, and they thought they would just because they weren't wearing a gown. I think in clinic we might just put on a glove.
Yeah.
So that was what the issue was.
That's super helpful. Then is the vaccine only once, or is there need for boosters like the COVID vaccine?
Oh, that's a great question. So right now we're prioritizing first doses of the Jynneos, but the typical situation is every 28, once after 20 days, and that's supposed to give you protection for years and years, and if not lifetime. But we don't know because this is a very different way of transmission with a high inoculum. So some immunologists think that, again, we're not really sure how the vaccine will perform fully, but it will probably prevent serious and bad disease, just like the COVID vaccines. But so right now, first doses only, but once they multiply by 5, they will give doses 28 days apart, because immunologists think that it's the number of times you remind the immune system rather than how much you give it up front. So I think the 28 days will probably stick, but probably not needing much more after that.
That makes sense. What are the options of treatment for those from the developing countries where the vaccine or the antiviral agent are unavailable?
Yeah, so the other drugs with activity, which countries have, but they are a little bit more toxic. So I would only use them if there was no other choices. Cidofovir, like what we use for HIV, CMV, or brincidofovir, which is the sort of like kind of gentler version. But apart from that, so if somebody has really serious disease, usually people may have access to those drugs, at least from somebody because of its use for resistant CMV and HIV. But yeah, so but luckily, I think it's really important the things that kill patients are not really the monkeypox. They're like a burn patient. So you have to really pay attention to hygiene and treating the patient like a burn patient if the rash is very extensive, because it's a super infection that can be killer. So just early recognition of that, institution of antibacterial antibiotics could probably be the best thing you can do.
Right. Are there any potential animal reservoirs for monkeypox in US that we should be concerned about, like COVID entered the white-tailed deer population?
That's a great question. I mean, when you talk to vets, they're not really sure. Certainly, we know it affected prairie dogs in 2003. It may affect rabbits. Rabbits carry a lot of other diseases here in the US, like tularemia and things like that. But nobody really knows for sure. And the rat, of course, I mean, the problem right now is that it's detected in the sewage system. So if rats get exposed to it, people worry that it'll get into the rodent population, and then it will be really tough to eradicate.
All right. Is the immunity acquired during an infection permanent?
Yeah, so I mean, again, I have to start off everything by saying we don't know everything for sure, but most people believe that once you get exposed, right now you have lifelong immunity to monkeypox.
Okay. As far as children, because it's very common for them to have skin to skin contact, they hug all the time. It's at schools and at like daycares. I think there was a case of exposure of children from a daycare person. So is there any way to prevent exposure in children or prevent monkeypox infection in children,
I think you really need repeated contact with someone. So say in that case in Illinois where the preschool teacher had monkeypox, I think it's a low risk because they're wearing, because when we know that even with zoster, when you cover the zoster rash with clothing, it cuts down the risk tremendously. So if the teacher was covering the rash with clothes, which it likely was, there's very, very little risk of respiratory spread. It has to be really close for multiple hours, not like in a fluid situation like that. So I think it's possible, but the risk is only going to get more if it bleeds over into the general population. But for right now, the risk is low. But again, things change over time. So
right.
yeah.
I guess the masking can help too, because the skin to skin
Yes.
might be hard.
Well, the mask will help with COVID and with monkeypox.
Exactly. A question about distinguishing hand, foot, and mouth disease in kids from monkeypox rash,
Yeah, so I think the main thing to do now is just send a PCR test. But in terms of hand, foot, and mouth disease, you don't see as much disease in the torso or in the arms and the extremities, mainly mucosal area, and which are really painful. So if it just stays there, and if the kid doesn't have a credible exposure, it's most likely going to be, Coxsackie virus or something like that, but not monkeypox. But you can always send a PCR. It's easy enough to do.
Right. Our classroom in Cameroon, do you guys have any questions? And Bill, do you have any other questions? And if anybody has any other questions, please feel free to put in the Q&A. I think we have addressed all of them. So there's another Q&A. Any role for serological testing and diagnosis? CDC mentioned IgM assay as a criteria for a probable cause.
Yes, so there is a serology test. The CDC is the only group that does it, and you can request it from them on a patient-to-patient level. And the scenarios are I mean, certainly the PCR is great for what you have now, but say the person had something and then they already recovered, you're not going to be able to PCR anything, or they would misdiagnose, and you want to know if they should get a vaccine or not. So that's the situation where a serology test would be good. And you can get in touch with the CDC, and they will do it for free. It's part of the service where they can do an IgM and an IgG for monkeypox.
Right.
Peter, this is Bill again. So one question is, for essentially a sexually transmitted disease, I'm thinking about all the others that have come about, and of course with AIDS. Do you think that this is going to extend beyond this population into sex workers, and then of course into the heterosexual population? And what's the likelihood of that becoming an endemic disease at this point, do you think?
I think, I mean, if I had to guess a number right now, it's probably going to be 60 or 70%. They already started talking about people experiencing homelessness now as another target group for vaccination, because they worry that it's going to get into that population. I think colleges starting up right now in the middle of a curve that's going steeply up is also worrisome too, because we've seen college students transmit lots of other close things like, MRSA and things like that. So, this next few weeks are going to be very critical in terms of that bleed over into the general population. And the more it bleeds and the more it stays, the harder it is going to be to control, and the more and more vaccines you're going to need. So it's kind of a very silver moment right now. And that's why the US, in an unprecedented way, with just one main study, really approved the multiply by 5 times vaccines, because they realize if they don't do something now, it's the chances of bleeding over is going to get bigger and bigger.
Yeah, that was a great question, Bill. And Dr. Dillon is the co-founder of Health for the World. I'm sure all of you know him. Okay, and then we have the classroom in Cameroon. Dr. Shinda in the group, do you have any other questions?
Yes, Dr. Bob here.
Yes.
Yes, so we're just really thankful. There were some questions in the group, but most of them were already asked and beautifully answered by Dr. Peter. So we just feel really privileged and thankful to have been invited to participate in this.
Thank you, Dr. Shinda. And Dr. Shinda is the program director of the internal medicine residency program at Bingo Baptist Hospital in Cameroon. So thank you. There's one more question, Peter. What were the crucial factors that were able to contain the monkeypox epidemic in 2003?
That's a great question. So the CDC did a lot of fantastic work. It's probably one of their best work that they've done to control it or contain an outbreak. And it was what Bhavya talked about, which is ring immunization. So they basically had the prairie dog pet owners and they immunized everyone who was in their contact. So it stopped the chain of transmission. And that's how it was successful. And nobody died, everybody did well. But it requires a lot of resources, and you can imagine thousands and thousands of people now. It's hard to do ring immunization, although they've done that in polio and earlier smallpox before. And now, as people know, polio is getting a little bit of a resurgence in the US, UK, and Israel right now.
Yeah, unfortunately, I remember I used to give the oral polio vaccine, back in India, in villages, and it's really hard to see it come to New York now. Okay, so I think those are all the questions. So, but thank you so much, Peter. You're an excellent educator, and always a pleasure to have you. I see a lot of thank yous in the chat. We have people from Nigeria, Cameroon, Sri Lanka, Bhutan, Mexico, US, Chile, who have joined, and I'm sure many other parts of the world. So this is really impactful. Your talk was so informative and so clear, especially during this time. So we really appreciate it. Thank you so much for doing this for us. And thank you everyone for joining today.
Thank you, Bhavya. Thank you, Bill. And to all the audience members, it's my honor. Thank you.
Yeah,
thank you, Peter.
Thanks, Bill, for joining. All right. Have a great day. Take care.